Our next speaker is Jessica Cicero, who is a physician assistant at Twin Cities Orthopedics. Ms. Cicero works with sports medicine Dr. Jonathan Cooper to bring patients relief from pain. Additionally, she helps them learn to take a more active role in their personal health. Today, you will learn about common medications, costs, types of injections, their benefits, drawbacks, and the treatment period. Please welcome Jessica Cicero.
Hello, everybody. I'll try and get this up. All right. All right, so I'm hoping everybody can hear me. Again, my name's Jessica, and today we're going to talk about common orthopedic injections, specifically what types are available, how effective they are, and when they work the best. So a little bit about me. I've been working in sports medicine for about 7 years now, primarily with one doctor, but in big facilities in which I would help out with multiple other providers. And I would also, I also did like a sports medicine fellowship in PA school. So I spent a year working with some of the top doctors in orthopedics in Chicago. And so I feel like one of my favorite aspects of my job is educating patients. And so even though we work in surgery, I love doing surgery. We spend a lot of our time actually talking about non-surgical treatments for a lot of these problems. So I don't have any financial disclosures, and I won't really be talking about off-label uses of medication. I do briefly mention it, but I'm going to tell you the real recommendation for the use of that medication. So of course, today we're going to identify the types of medications that we frequently use, the common problems in which we use those injections, the benefits and potential risks, and when available, the AOS recommendations for each therapy. So it is fall officially, so I thought what better fall presentation. We're going to do a little football presentation. So what are we working with? Who are the players that we're using in these treatment options? The most common one that most people know about are the steroids or the corticosteroids, also called cortisone in to a lot of patients. These are potent anti-inflammatories that are injected directly into the site of injury typically with a local anesthetic, and their job is to reduce inflammation. As soon as we inject these medications, the local anesthetic starts working within about 30 to 45 minutes, and then the steroid takes about 5 to 7 days to work, and it gets to maximal effect in about 6 weeks. It gets to maximal effect in 5 to 7 days, and then it lasts about 6 weeks. These are relatively inexpensive. They're about $50 to $200 per injection, and however, they do come with some risks associated with them. The biggest risks associated with these medications are infection. Steroids can reduce inflammation, of course, which is the healing cascade, and so it can increase the risk of developing an infection. Another big risk is developing a steroid flare, which is increased pain and swelling for about 2 to 3 days following the injection. It doesn't mean that the injection's not going to work. It's just a little bit more painful in the process. Nothing you can really do makes it go away. It just, you just got to bide your time, ice, elevate, wait for the injection to really take effect, and it'll go away on its own. The other major concern with corticosteroid injections is in individuals with diabetes, as corticosteroids can actually increase the blood sugar levels in individuals, especially with diabetes, for about 2 to 3 days, and sometimes those can get quite elevated into the 300 and 400 level, and so individuals with diabetes really need to be cautious with these injections. The next medication or treatment that we talk about is the viscosupplementation injections, sometimes called hyaluronic acid, sometimes called HA, sometimes called the rooster comb injections. And essentially what it is its major component is hyaluronic acid, and we inject it directly into the joint. Our original thought is hyaluronic acid is a normal component in cartilage. So if we inject it into the body would use that as a building block, and it would restore normal cartilage in those individuals that it started to wear away. Unfortunately, we've gone in and scoped patients after doing these injections, and it doesn't seem to grow back the cartilage, but it does seem to act as a lubricant and a shock absorber in many patients, and that helps to reduce pain in individuals with osteoarthritis. It does come in multiple forms. The first is a single series of a single injection that involves 3 times the medication. The second is a series of 3 injections given 1 week apart. And then one medication is still recommended to be given as a series of 5 injections given 1 week apart. However, a lot of providers are giving these as a series of 3 injections, but the manufacturer still recommends it as a series of 5 injections given 1 week apart. My personal favorite for this is the series of 3 injections given 1 week apart for multiple reasons. One is I kind of think of this as like a vitamin. And so if you took all of your week's worth of vitamins in one day, you're not going to process it as well. The body needs time to process through this medication, slowly absorb it, and allow the body to use it as a lubricant and a shock absorber. The second reason is the single injection, although it's good for individuals that are very averse to injections and very scared about getting multiple injections, it does contain 3 times the medication. And 3 times the medication typically means more pain for individuals because that joint capsule is getting stretched out even further. And it typically can cause higher risk of an allergic reaction in individuals as you're now being exposed to 3 times the medication. These injections do take about 6 to 8 weeks to come to full effect, but in individuals that they work in, they can last between 6 months and 2 years. They don't work in everybody. Only about 2/3 of patients that receive these injections have benefit from them, but in the ones that they are working for, they can be fairly beneficial. They are a little bit more expensive. They typically cost about $1,200 to $1,500 for the series. And there are some risks, of course, associated with that. Biggest risk for these medications are an allergy or anaphylactic reaction. Specifically, they should be used in caution in individuals with an allergy to avian products or an allergy to birds. That is because this medication, although it is now synthetic typically, it was originally isolated from the comb of a rooster, and it can still have some of those side effects or allergic reactions in those individuals. The other main risk is a local site pain. Because we do give this injection 3 weeks apart from each other, they are getting poked multiple times in the same location, which can exacerbate the pain week after week. There is some debate whether these medications should be used or not due to their cost effectiveness, as they only work in 2/3 of individuals, and they are much more expensive than the corticosteroid injections. But in the individuals that they work for, they do work very well. And then the last treatment option isn't actually a medication at all. It is a treatment, and what it is we isolate whole blood from patients, and then we spin it down into a centrifuge. And with that centrifuge, we isolate this platelet-rich plasma, or this yellow layer. I don't know if you can see my mouse, but this yellow layer we isolate, and then we inject it directly into the site of injury or damage. That plasma layer contains or a high concentration of platelets, which then help mediate the balance of anabolic and catabolic forces in that area of damage. Now, the catabolic forces are going to be the pro-inflammatory, the inflammation, and the platelets help to inhibit that response, and the anabolic forces are the growth factors that promote cartilage growth, tendon tissue cartilage growth and regenerate tendon tissue through collagen synthesis, vascularization, and tendon cell proliferation by inducing those nearby cells to produce more growth factors. So we're stimulating the good cells in the area of damage to produce these growth factors. There is some discussion about whether we should do leukocyte-rich or leukocyte-poor PRP injections for specific injuries. However, most providers don't go this in depth because it does require further centrifugation and specifically isolating the correct leukocyte-rich or leukocyte-poor formulation. It's just more labor and time intensive. And the reason why this has been looked at is because they think that the leukocytes or the white blood cells can produce more of a catabolic effect, and that catabolic effect may antagonize the anabolic effect of the platelets. Interestingly enough, since this is not a medication, this is a procedure, the cost is variable. At the place that I currently work at, these typically cost about $800 per injection. At my previous employer, it was about $501 per injection, and where I studied, the cost of PRP was $750 per injection. However, they typically recommended as a series of 3 injections given 1 week apart, similar to the hyaluronic acid injections we just discussed. And but they would give you a steep discount of $2,100 for the series of injections. This is not covered by traditional insurance companies. And so this is something that we discussed with individuals that it may be an out-of-pocket cost for them. Now I'm going to show you a video, if it will let me, because I think it's really interesting how they isolate these platelets.
Autologous conditioned plasma, ACP, is a new technology that concentrates platelets and growth factors within a plasma layer, separate from white and red blood cells. Outside of the bloodstream, platelets become activated and release proliferative and morphogenic proteins. These growth factors are known to be important for healing in a variety of tissues. Prior to beginning the process, it is best to break the seal of the 2 syringes as shown. The process begins by adding anticoagulant, ACDA, to the double syringe system. The outer portion of the syringe is pulled back to withdraw the ACDA. If the plasma is going to be used within 30 minutes of blood withdrawal, the ACDA is not required. Approximately 10 cc's of blood is then removed by again pulling back on the outer portion of the syringe. If ACDA is used, the blood is gently mixed and then placed in the centrifuge. A counterbalance must be placed in the syringe. The blood is spun at a rate of 1,500 revolutions per minute for 5 minutes. When centrifugation is complete, the double syringe is removed from the bucket, taking care not to tip or agitate the separated layers. The yellow plasma layer is then removed by gently pushing down on the outer portion of the syringe while pulling back on the innermost plunger. You can see that the plasma is drawn into the second syringe, leaving a small amount of plasma remaining in the main syringe, so as to avoid disrupting the lower red blood cell layer. The inner syringe is then twisted in a counterclockwise direction and removed. A needle or cap is placed in the syringe for use at the point of care.
Okay. All right. Now somebody did ask, are we going to discuss for which body parts PRP works the best? Yep, we're definitely going to do that. So actually, now we're going to start talking about what are we fighting against. Let me get this back up. There we go. So what are we fighting against? Are we looking at something that's just more annoying and persistent, or are we discussing something that's more aggressive and angry? So as you can see, there are lots of conditions in which we discuss injections for individuals with orthopedic conditions. Today we're going to just talk about these first 7, and we'll start from the bottom up. And so we'll start with some plantar fasciitis. So plantar fasciitis is one of the most common causes of heel pain in adults. It is likely due to degeneration of this plantar fascia tissue, which is a fibrous tissue that connects the heel to the toes. And it's actually a misnomer. Itis typically means inflammation, but it's not inflammation. It's more likely due to tendon degeneration or tendinopathy. And it is typically presented with non-traumatic onset of focal heel pain. The pain is typically worse in the morning or after long periods of rest, and that's because when you're at rest, the foot sits in a plantar flexed position in which the toes are pointed, and that plantar fascia that sits underneath the foot is tightened in that position. When you get up and walk first thing in the morning, that foot is placed in a dorsiflex position, and that stretches that plantar fascia right at the bottom, causing heel pain. The pain is typically resolved with sitting or resting because that foot is allowed to then rest in that plantar flex position again. Sometimes heel spurs can be seen on x-ray, but this is not the source of the pain. This is actually a symptom of that chronic tendinopathy right at that heel, causing some pulling at that bone, causing a spur. Treatment is very long in these individuals. It typically lasts about 6 to 12 months of conservative treatment, but it is very successful. People feel better in about 95% of the cases after 6 to 12 months worth of conservative treatment. Conservative treatment does consist of activity modification, which means for avid walkers and runners, they will have to modify their activities and transition to like biking or swimming. And then we also do anti-inflammatories like ibuprofen or Aleve, ice, gel or rubber heel cups, and a home exercise program that focuses on heel cord stretching. In individuals that have that first thing in the morning pain, we can recommend a night splint that holds that foot into a dorsiflexed position, and that stretches out the plantar fascia while they're sleeping instead of tightening it, and so then they don't have as much pain when they first put those steps down. So this is an example of plantar fasciitis, of the heel cord stretching for plantar fasciitis. This and many other home exercise programs could be found on the AAOS website, which is where I got this one. And it's just a great resource for individuals to show them some of these home exercises. When conservative treatment of a stretching program, ice, heel cords, heel pads, and anti-inflammatories has failed, we do discuss corticosteroid injections. We recommend that all x-rays, or all individuals with plantar fasciitis receive an x-ray prior to their injection, just to determine the thickness of their soft tissue between the skin and the heel bone, the calcaneus, and to determine if there is a spur that we need to look out for with the injection. The needle is then directed directly into the heel bone or the calcaneus, and then it's angled towards the toes until it falls into that space in which the plantar fascia inserts. This can be a very painful injection in many individuals. If you've ever met anybody that's had an injection in their plantar fascia, they probably didn't like it very much, but it is also typically very successful in those individuals. It should be done with caution, as if it is injected too superficially, it can cause some cell death in the fat pad that sits between the heel and the skin, and then that would cause some loss of cushion in the heel, and that would be a source of possible chronic pain for these individuals. Next, we're going to talk about knee arthritis. Now, knee arthritis is our bread and butter in the orthopedic community, of course. It is one of the most common chronic degenerative diseases. It affects 47 million Americans every year. It is characterized by gradual or post-traumatic degeneration of the articular or hyaline cartilage, and it is a progressive disorder. As you can see, it can go all the way from just some softening of the cartilage structures, all the way to bone-on-bone degeneration in which the cartilage is completely worn away. It is characterized by pain as well as loss of function within the knee, and this includes both range of motion and strength, which can affect individuals' quality of life and their ability to work. Our treatment options are very variable. They range from just activity modification or avoiding the aggravating activity all the way up to total knee replacement. Now, knee replacement is a great option for older individuals and those with that advanced disease. However, younger individuals and those with more mild to moderate disease don't do well with knee replacements. So then we typically talk about conservative options, which include activity modification, over-the-counter anti-inflammatories, proper nutrition and weight loss if needed, physical therapy, bracing if appropriate. But many people have already tried all of these options before they even come in to see us. And so that's when we start talking about injections. So the knee arthritis is one of those conditions in which we talk about all three of the different types of injections. Individuals with acute exacerbations of knee arthritis pain could benefit from corticosteroid injections, as the studies do show that they provide moderate benefit in individuals' symptoms for about 2 to 8 weeks following the injection. This is considered more short-term improvement. The AAOS does not recommend for or against corticosteroid injections in individuals with knee arthritis. Viscosupplementation injections, or those HA injections, there has been wide variability amongst the sources, amongst research regarding their effectiveness. In clinic, we see about 2/3 of individuals having improvement, but many studies do not show that high of a number. And so they don't feel like the cost effectiveness for the hyaluronic acid injections are beneficial enough. So the AAOS actually no longer recommends viscosupplementation injections in individuals with knee arthritis. However, there has been a Cochrane review of studies that show that it could be useful in the treatment for more moderate term improvement, especially in individuals where other treatment options have failed. And then finally, we start talking about PRP injections in individuals. And multiple studies have shown that PRP is at least as good as hyaluronic acid at 6 months and is actually better than hyaluronic acid at 12 months following the injection for both improvements in pain and function. Still more studies are needed to confirm, therefore the AAOS has not recommended for or against the use of PRP injections. Again, as this is not typically covered by traditional insurance companies, we do not see a lot of people that are willing to pay the cost for these PRP injections. So when I see a patient in clinic, if they have had chronic arthritis type pain, they've been managing it, but then they slipped and they fell and they twisted their knee and all of a sudden their pain significantly higher. That's when I would recommend a corticosteroid injection. If people are chugging along with their chronic pain and then all of a sudden their chronic pain is just gradually progressing and progressing. And now they can't walk a couple of blocks. Now they can't, walk up the stairs to their bedroom, and they're having those sort of limitations, but they haven't had an acute injury. That's when I would typically recommend a viscosupplementation injection. And I personally don't recommend PRP injections to a lot of patients unless they've failed both corticosteroid injections and viscosupplementation injections, and they haven't wanted to, or they don't want to discuss any surgical options at that point, just because most of our patients cannot afford the out-of-pocket cost or do not choose to afford the out-of-pocket cost with PRP injections. Then we will talk about meniscus tears. And the meniscus is two C-shaped pieces of cartilage that sits within the knee. There's one on the medial and there's one on the lateral aspect of the knee. It's a type of fibrocartilage that can be torn either acutely or chronically, and it acts as a shock absorber for typical motions within the knee. The individuals with acute tears are usually formed after acute twisting or pivoting activities, or sometimes like car accidents. And the degenerative tears are usually caused after low mechanism injuries like getting up from a chair or squatting. The location of the tear is very important. As you can see here, there's this red zone and this white zone. Tears within the red zone are more likely to be repairable, and the tears within the white zone are less likely to be repairable. However, the type of tear that's formed is also important with whether it could be repaired or not. Most orthopedic surgeons agree that if preservation of the meniscus tissue is very important to prevent further progression of their arthritis. And so therefore they all agree that if a tear is repairable, it should be repaired. Meniscus tears are often associated with pain and swelling within the knee joint, but individuals may also experience catching, locking, or instability. If an individual is experiencing locking or instability, this does put them at high risk for future injury, and therefore we do recommend surgical options. However, if somebody is not experiencing mechanical symptoms such as locking, and it is not a repairable tear, we recommend conservative treatment. This typically involves physical therapy, anti-inflammatories, rest, ice, compression, and elevation. After they've failed all of those options, we may discuss a corticosteroid injection with or without an aspiration or removing the fluid that develops inside that joint, as it can be beneficial in individuals with significant pain and limitations, particularly in those that cannot complete their physical therapy because of these limitations. Studies show that it provides a similar relief as with osteoarthritis, therefore some moderate improvement in that short term, 2 to 8 weeks worth of relief of their symptoms. But in individuals that have had an acute tear, or in individuals that have a chronic degenerative tear but had an acute inflammation, this might provide them more long-term relief until a future exacerbation occurs. Many individuals with meniscus tears can become non-symptomatic if they perform these conservative treatments. Even though their tears can't repair themselves, they can have no symptoms. They can go on with life without having any problems. Unfortunately, hyaluronic acid injections are not approved for individuals with meniscus tears, and the AAOS does not discuss its recommendations for corticosteroid injections in individuals with meniscus tears. So then we're going to talk about spinal stenosis. We're going to kind of bounce back and forth a little bit. So spinal stenosis is narrowing of this spinal canal right here that causes compression of the nerve roots as it comes out of the particular facets. And it can be caused by many different reasons. It could be caused by facet joint arthropathy, disc herniation, spondylolisthesis, which means one disc slips forward upon the other disc, which would then decrease that space in there. And it can also be caused by spondylosis, which is arthritis within these joints right here. About a third of individuals with spinal stenosis are asymptomatic, and that's because you have to have at least 30% of the spinal canal restricted in order to have symptoms with these individuals. But when they do develop symptoms, they typically follow these dermatomal patterns as seen by our little colorful guy up in the top corner, as those nerve roots typically supply the sensation to that area. Individuals can also experience what's called neurogenic claudication, which means the longer somebody is up and moving around, the more symptoms that they will have, and then the symptoms typically improve with sitting or laying down. This also is sometimes referred to as the shopping cart sign, because when people are up shopping at like the grocery store, they're chugging along, starting to have more and more pain, and then as they go, they start leaning over the shopping cart because that mimics the sitting down position and takes some of the pressure off of those nerve roots. If individuals are having neurological symptoms, such as weakness in any of their extremities, or if they develop cauda equina syndrome, these should be evaluated urgently, as they will likely require surgery. And specifically for cauda equina syndrome, it would require urgent surgery. Now, as you can see, this is an MRI image of the low back. And here is the spinal canal. We cannot see the nerve roots coming out in this view. But right here at L4, L5, and L5, S1, we can see this bulging of a cervical or intervertebral disc that is pushing onto that spinal canal. And specifically at L5, S1, we'll look at this different view, and you can see the nerve root coming out here on the right-hand side, but the intervertebral disc is compressing on the nerve root coming out on the left-hand side, and that is causing symptoms most likely on their left side. Treatment is typically conservative unless, like I mentioned, they're having neurological symptoms or cauda equina syndrome. And it typically focuses on physical therapy, specifically core strength and lower extremities stretching exercises. However, epidural injections are frequently performed. And this is quite interesting, is that typically they're performed with a local anesthetic, and sometimes corticosteroid injections are added to it. Newer studies are showing that a local anesthetic injection alone may be as beneficial as a local anesthetic and corticosteroid injection. So many people are starting to just perform local anesthetic injections into these areas. And these have been shown to provide improvement of pain relief, function, and decreased opioid intake. The newer studies are also showing that if somebody is getting good benefit from an epidural steroid injection, they will also receive benefit, a similar benefit to surgical measures if it does get to there eventually. The injections can be performed via the caudal, or coming from underneath, intralaminar, coming in between those two lamina, or directly into that foramen where the nerve root comes out. The transforaminal injections are the most effective, as they are done under fluoroscopy. And that does lead to a higher cost, however, because of the fluoroscopy cost, and then typically they require sedation. Individuals that receive an epidural steroid injection can have some side effects from that, including headaches, increased back pain, vasovagal reaction or passing out, and leg pain. So those should all be discussed with the individual prior to receiving the injection. And as I mentioned before, the cost is a little higher due to the sedation and fluoroscopy. All right, so now we're going to get up into the upper extremity, and we're going to talk about tennis elbow or lateral epicondylitis. This is another one of those itis that you would think means inflammation, but it is, again, a misnomer. It is more of a tendinopathy, not a tendinitis, but it is one of the most common soft tissue injuries. It affects between 1% and 3% of adults each year. And in the past year, I have had to personally counsel both my father and my aunt, his sister, through their lateral epicondylitis. And as you can see a little later, it's not super easy to counsel people through it that just want to feel better. This is caused by mechanical overload at this common extensor tendon where it inserts into the lateral epicondyle. And it's typically associated with abnormal microvascular changes at this area, hence the tendinopathy or diseased tendon and not inflammation. The dominant elbow is most commonly affected as it's the one that's more responsible for a lot of the wrist motion. It's characterized by pain at the lateral aspect of the elbow, especially with wrist extension and pronation. So if you're thinking about a backhand in tennis, that's when those individuals are going to be experiencing most of that pain. And then they also have decreased grip strength most of the time. Treatment frequently involves activity modification. And individuals that do play, that are avid tennis players, this includes overwrapping their tennis racket handles to increase the grip strength, reducing the tension on their racket strings, over-the-counter anti-inflammatories, including the topical anti-inflammatories, which I have to make a little plug. While I was on furlough for the COVID pandemic, I was flipping through a Target ad and I got so excited because my favorite topical anti-inflammatory is now available over the counter at like Target and Walgreens. And I called like 4 people and I was like, oh my gosh, Voltaren's now available over the counter. And they're like, oh, okay, that's great. And I'm like, no, this is like really fantastic. And recently, like I had mentioned, I had talked to my aunt about her lateral epicondylitis, and I recommended Voltaren gel to her. And within a week, she texted me, and she's like, this medication is so great. I really appreciate you telling me about it. So it can be a great option for many individuals. We can also recommend a elbow strap, which would go just below that lateral epicondyle. And it makes a new source of origin for those individuals and that tendon. And so then it offloads the lateral epicondyle. And then physical therapy that starts with gentle stretching exercises and then progresses to some strengthening exercises slowly. When these options have all failed, we do discuss local injections. Now, historically, corticosteroid injections have been considered the gold standard of treatment for people with lateral epicondylitis. They can provide some short-term relief in individuals, especially with severe cases, and that allows them to perform their physical therapy exercises. However, corticosteroids have also been known to be associated with a higher recurrence rate. They can cause some permanent damage and cell death within the tendon, and they actually slow down the healing within the tendon because inflammation sometimes is good. We want some inflammation to come to the tendon to produce healing of that tissue. So more recently, we have discussed adding PRP injections, and more individuals are performing PRP injections into the common extensor tendon at the insertion at the lateral epicondylitis. Studies are showing that they are at least as effective and maybe more effective than corticosteroid injections, particularly at the intermediate term of their post-injection course. And so it can provide some longer relief of those symptoms. Now, this is one of those rare circumstances where that leukocyte-rich, leukocyte-poor might be more looked upon. We still definitely need more studies to confirm this, but there's some thought that the leukocyte-rich PRP formulations may be more beneficial than the leukocyte-poor PRP injections, but again, needs to be studied further. Again, however, because they're not covered by typical insurance companies, many individuals don't want to discuss them as they can provide more out-of-pocket costs for them. And then we're going to go up to the shoulder and discuss rotator cuff tendinopathy or shoulder impingement. So this is caused by inflammation at the fluid-filled sac or bursa that sits in between the rotator cuff and the coracoacromial arch, or the underlying rotator cuff tendons. It's likely due to a combination of both mechanical insult of this coracoacromial arch, or this bony structure, onto the bursa and the tendon, as well as some decreased vascularity within that tendon as we age specifically. Individuals typically experience pain with moving the arm away from the body, especially above shoulder height. It is not associated with muscle weakness or atrophy. If there is muscle weakness or atrophy, we need to consider a rotator cuff tear. Treatments of rotator cuff tendinopathy typically consist of physical therapy and anti-inflammatories. And the physical therapy would typically consist of scapular stabilization to try and open up some of this space a little bit, posterior capsular stretching, and then gradually adding in some rotator cuff strengthening exercises as the symptoms improve. After 6 weeks of physical therapy, if a patient hasn't had any symptomatic improvement, or if they have been unable to participate in physical therapy due to their symptoms, we would consider a corticosteroid injection. Studies are showing that these are not superior to physical therapy in the long term, but they may allow for more effective physical therapy and may allow for people to participate in physical therapy more effectively. It is sometimes associated with some rare cases of septic bursitis. Just like with all corticosteroid injections, it can increase the risk of developing an infection, but septic bursitis is something that we need to look out for. Other things that are being studied for rotator cuff tendinopathy includes PRP injections. And studies show that there are comparable improvements for both pain and function when compared to corticosteroid injections. And this could be a safe alternative to corticosteroid injections for rotator cuff tendinopathy. However, it's not a first-line therapy due to the cost comparison and the fact that traditional insurance companies do not cover it. Finally, we're going to talk about tears in the rotator cuff. So the rotator cuff is a series of 4 tendons that hold the ball and the socket portion of the shoulder together. There's 1 tendon in the front, 1 on the top, and then 2 in the back. The most commonly affected tendon is that top tendon, or that supraspinatus, as you can see in these pictures. However, the tear can extend anteriorly or posteriorly as well. And those tendons are responsible for rotating the shoulder and stabilizing that humeral head into the socket. Most tears in individuals are the result of age-related degeneration in that tendon. However, in our younger individuals, specifically those in their 40s and 50s, they're more likely to be caused by acute injuries, in which we see a lot of our worker comp patients coming in for. Many individuals, by the time we're in our late 60s, early 70s, into our 80s, many individuals have already torn their rotator cuff and they've never even known it. However, they can have some increased pain when they exacerbate that previously torn tendon. So the symptoms of a rotator cuff tear are chronic or acute onset of shoulder pain. That's often associated with weakness, sometimes injury, grinding, and then difficulty raising the arm above shoulder height again. Many individuals with rotator cuff tears describe some difficulty in specifically with sleeping. So When the tears are acute in our younger individuals and they're having weakness, we oftentimes recommend surgery so they can maintain or regain their function that they previously had prior to the surgery. However, with those individuals that have those chronic tears, a corticosteroid injection may be effective for those acute exacerbations. Again, it can provide some short-term pain relief, but decreasing that inflammation, decreasing the risk of having more pain until they were to get a further exacerbation. These should be used in caution, of course, because in individuals with these chronic rotator cuff tears, if they were to receive more than three or more corticosteroid injections and then elect to move on to a repair in the future, there is some risk that they could potentially have a higher failure rate in these individuals. So if somebody is just saying, I just need to buy my time until I can get to the surgery, we definitely need to educate them. And the more injections you have, it possibly could decrease your healing rate if you do eventually have surgery. This hasn't been proven in many studies, but it is definitely a risk that we need to discuss with individuals. As for PRP, in individuals with rotator cuff tears, it's likely to provide similar pain relief as individuals with rotator cuff tendinopathy, so fairly good pain relief, or at least comparable to corticosteroid injections for non-surgical patients. But very interestingly, there has been studies that show that in individuals with small to medium rotator cuff tears, if they undergo a surgical procedure to repair their rotator cuff, and they have this double bundle rotator cuff repair, and then we inject the PRP right underneath that rotator cuff, it could potentially decrease the re-rupture rate in these individuals, and it could also decrease the post-operative pain in these individuals. Now, this hasn't been further studied. We definitely need to study this further to see if this is a potential outcome, as if any of you have ever met anybody that's had a rotator cuff repair, they will tell you it is potentially one of the most painful surgeries that they go through. And that's something that I frequently talk with our patients before surgery and say, you might have had surgery before, but you've never had surgery like this. This is going to be a very painful recovery for you. Right now, it is not the standard of care, unfortunately, for rotator cuff repairs, but maybe potentially in the future, we'll be seeing that as well. So these are all of the references that I used. And I'd also like to thank, Dr. Cooper and all of the physicians that I worked with through Twin Cities Orthopedics, through TRIA and Health Partners, and then, of course, through Midwest Orthopedics, where I did my training, who've worked through a lot of this stuff with me. And I'm happy to answer any questions that there may be now. I'm scrolling through the chat really quick. So what I see is somebody asked, do I see plantar fasciitis caused by work injuries? I do. Typically, it's from more factory type workers that are standing for long periods of time. They don't have mats to stand on, and so they're walking on their stretched out plantar fascia a fair amount. It's, of course, one of those injuries that it's potentially questionable whether it was caused by work or if it was caused by something else, but we do see patients with plantar fasciitis.
Jessica, can you hear me?
Yeah, I sure can.
Okay. Oh, great. So I had three questions. One is, four. What are the thoughts with dry needling with epicondylitis?
I've sent many patients to get dry needling. The very similar thoughts to PRP, actually. So Whole blood is a type of, it's a component within PRP is a component within whole blood. So the thought is we would go in and we just poke little holes into that tendon that connects to the lateral epicondyle, and it produces a healing cascade within the body. So the bleeding brings healing factors, and it can reduce that tendinopathy or regenerate that cell growth in that tendon. So it's kind of like a mini PRP, so to say, and not just in lateral epicondylitis. When we're in surgery, a lot of times when we're doing meniscus repairs or if we're doing rotator cuff repairs, we stimulate bleeding in the area in which we're repairing to help bring that blood flow and help bring that healing cascade to the area. I like to tell a lot of my patients, I am a surgical PA. My doctor is a surgeon. He's actually a DO, so he doesn't mind me saying this at all. But even the best surgeon in the world, he's not going to do anything to heal your body. He is putting things back where they belong, and your body is healing itself. Once we get the things back where they belong, your body and that healing cascade forms that scar tissue layer that then causes healing long term.
Okay, next question is, what efforts are there in the medical community to get PRP injections covered by most insurances, including workers' compensation?
You know what, that's a great question, and I'm not sure what is currently going on with that process. I don't specifically perform the PRP injections, but I know our doctors that do perform the injections, they are frequently advocating for their use and their coverage. I worked with one doctor specifically over at TRIA who was working hard to get insurances to cover PRP injections. As you know, a lot of individuals, they like that holistic type treatment. I love it. And so it can be a great option for individuals. So we're working on it.
Okay, that's great. Say, is the vascularity of tendons reduced as we age?
Absolutely. Yes. So tendons actually don't have a great blood supply. I'm going to pop back to that elbow. Well, actually, I can even show you in this rotator cuff. So tendons connect muscles to bones. This muscle, you can tell, is nice and red because that's where all the vasculature comes from. Tendons don't have a great blood supply. In that very distal portion, they don't have any blood supply whatsoever. So as we age, think of this like a rubber band. A nice new rubber band is really stretchy, and it has the moisture and the support from the surrounding muscles, from the vascularity of the muscles. But as we age, that rubber band starts getting stiffer and stiffer because these vascularization of the muscles tends to get further and further away from the tendon. And so it's not quite as stretchy anymore. And so that puts the tendons at risk for tendinopathy or tearing more frequently as we age.
And finally, what is your recommendation for people that get scar tissue after surgeries?
Yes, so it all depends on where your surgery is. If it's fairly superficial scar tissue, I've worked with some occupational therapists, some hand therapists, some physical therapists that really recommend scar massaging. So once the scab has resolved and it's just a scar that's present, you can really massage through that scar tissue if it's more superficial. Some vitamin E oil can help provide some moisture to that superficial skin and allow that to heal a little better. But in terms of like scar tissue for like deep structures like knee replacements or rotator cuff repairs, that's a little bit more difficult. Specifically with knee replacements, there's nothing that we're really healing. Everything's solid in there from the day we leave surgery. So working on that range of motion as soon as possible after surgery is going to be very important. ice. Ice is actually one of the best anti-inflammatories that we have. So that can help reduce some of that stiffness and swelling that's developing that allows you to work on that range of motion a little bit better. But there are just some individuals that develop a lot of scar tissue following surgery. And sometimes all we can do is bide our time, let things heal, and then we'd have to go in and manipulate it later after, which just means we put them to sleep and we bend their joint to keep it moving. For a rotator cuff repair, we put them in a sling for about 6 weeks after surgery. And so I don't know if you can see me. They're in a sling that sits about here, and they're not really able to move very much for those first 6 weeks, but we do let them come out of their sling to work on some pendulum exercises or Codman's exercises that we describe them, and working on their range of motion of their elbow, wrist, and fingers to help prevent some of that scar tissue from developing. And then as soon as the scar tissue, the good scar tissue that's developed to repair that tendon to the bone has formed, and we can allow them to start moving it a little bit more, we have them really work on their range of motion.
Ms. Cicero, thank you for your extremely informative presentation. Would you have any closing comments before we wrap up?
Yeah, I would love to show you guys. So this is just our Twin Cities Orthopedics general website. And if you go to me in Physician Extenders, or if you go to my doctor, John Cooper, through this, we do have a whole bunch of resources for patients, as you can see on this left side over here, that discuss frequent injuries in individuals, tells them a little bit about what they're experiencing. And then we also have some post-operative guidelines for individuals if they are undergoing surgery to try and tell them what to expect following surgery, and how the recovery is likely going to be. So there are some really great resources for individuals if people are a little bit more nervous, or they don't feel like they've gotten the amount of education that they feel is appropriate.
Well, wonderful. Thank you again, Ms. Cicero. That was very informative.
Thank you.